Hello, my name is Talia Gonzalez, and I will be presenting my final research project on accounting and healthcare field for MBA course 840. Accounting and money management in general is essential to our economic growth. With healthcare being the largest influence in our economy right now, it is important that we have a sustainable way to manage the in and out of that revenue. In the early days of healthcare, we as a nation focused on the treatment and diagnosis of acute issues such as colds, flus, injuries, things like that. Now we focus more on chronic issues, things such as ongoing pain, hip pain, leg pain, things like that. Treatment of chronic diseases like HIV, diabetes management, and of course cancer. The change in how we treated people in terms of healthcare changed how we did things such as bill for services and how those bills reflect an ongoing situation or an ongoing condition. We also have to look at third-party servers who assist in helping to pay for healthcare services and how those third parties also change the spike in the pricing of healthcare as well. In terms of money influx and management, we look at the revenue cycle management of a healthcare facility. This process will look at things such as collecting co-payments, claims tracking, determining patient eligibility, and following through on denied claims. The biggest thing that we see, of course, is going to be collecting co-payments. Co-payments is simply just going to your doctor's visit and your insurance requiring some type of fee. It can range from anywhere from $5 to $100. Anything less or more than that as well, that your insurance requires or your healthcare third-party assister helps with. So the biggest thing with collecting co-payments is not collecting co-payments. Most healthcare facilities cannot turn away a patient because they cannot afford their copay. So if a patient can't afford their visit or for whatever reason refuse to pay their copayment, they can't be turned away for their services, and they can still be seen for whatever brings them in. The biggest problem that we see with this is that there's no way to force someone to pay a bill. When there is no way to make someone pay a bill, this falls into a claims tracking area, which will also fall short on the auditing, because after a certain time, it may be forgotten or referred to other departments, which places a failure on the claims tracking department. There's also the issue of a patient just simply not paying for it. Other issues that arise with this is the changing of patients' insurances, which changes their eligibility. So at one point, they may not have had a copay, and after changing, eligible benefits may require one, and that in turn may take a lot longer for it to process, and it could cause a delay or a backup in services that were billed and now get pushed onto the patient all at once. The same occurs on the opposite end when a claim is denied by insurance, leaving a burden on the patient that requires them to pay a bill themselves. And sometimes it can either be written off in some way or just given to the patient as a constant reminder. But again, no repercussions are given, as you can't force someone to pay something in terms of healthcare at least. There are different ways to manage these issues, and different healthcare facilities work with the best methodology that works best for their patient population as well as economy. The most common methods are a cost design, traditional costing, activity-based costing, time-driven, performance-focused, and ratio of cost to charges. So the first method that we'd be looking at is the cost system design. Cost system design was provided by Chapman and his colleagues in their article, The Foundational Role of Cost Analysis. Chapman and his colleagues saw that auditing was best done as a simple three-step method. He describes this three-step method as identifying and grouping together various types of resources, which would be identifying what services go with the patient as well as the financial background and putting that into a patient's profile. The next step is pulling the lines of cost into a cost pool that become applicable to that first group. So what this means is that getting all the cost centers which are identified at any facility and applying it to the patient's profile, and finally having the cost center applied to that patient's profile to create a number value of what the patient is having done and providing an estimate cost. The next is traditional costing. It is a very simple method of accounting. Traditional costing takes a predetermined rate of something and applies it to the healthcare facility. So, for example, an MRI may be quoted at $13,000 just baseline. That predetermined rate is applied to all patients across the board, regardless of any other factors. It's a very simple way of looking at things, and it's very beneficial for just an estimation. The downside of this is that a patient may not just need an MRI, and each body part may require other services such as dyes, or if the patient has anxiety, it may require administration of medication prior to the procedure, as well as even insurance coverages. Insurance is not covering a particular MRI versus another, and then again that goes into patient preference and a lot of factors that are added into that. These additional services may affect the estimation, in which will then throw off not just the patient, but the estimated cost that was placed, initially in the accounting books. The activity-based costing method is different because it takes an intended goal and resource pricing into account. So activity-based costing methods takes into account a preconceived goal, such as returning to normal health, and how that goal will be achieved, such as what tests, exercises, modalities, and whatnot need to be used or done in order to get that end goal of health. So it takes into account the cost of prices of those items and creates a better estimate of what is needed. The only drawback is that it does take an immense amount of time to cater this type of pre-context audit. This plan does not take into account if conditions worsen or gets better, and if the quoted plan does change. The next is going to be the time-driven activity-based costing, which is going to be very similar to the activity-based costing, but it takes into account the factor of time. So this works out a bit better because it will take into account how slow or quickly something takes to heal or finish, and then takes into account how these modalities, like the x-ray or the physical therapy treatments, will play a role in that time progression. So this method works out because it gives a time period which can change at any moment, but gives better quoted estimates and how that will play a role in the claims tracking, as well as give patients a better estimate of how much they will be paying out of pocket and the time expense. Performance activity costing is going to be a methodology of auditing that takes both aspects of time-driven and activity-based costing methods. The performance-based costing takes into account the time factor, as well as showing the relationship between the time it takes to do something versus how much of that time is spent using the actual modalities or materials. It basically makes sure that what is being used is truly needed, because time is going to be an important factor for not only pricing, but for everyone that's involved in the care as well. The performance-focused activity will take into account surveys and other materials to make sure that it truly is cost-effective, efficient, and most importantly, it's truly effective and useful. Finally is the ratio of cost to charges. Ratio of cost to charges is different because it's the only method that is specific to healthcare, but so specific that it only applies to Medicare patients. The other methods can be used for various other sectors of business, but this one is particularly set for this cohort. The ratio of cost to charges is a simple report that shows what costs are being allocated to particular services for those that fall into the Medicare program. It has no other significance other than being just a tool to use as a reference. The problem with this is that it can be manipulated in a way that shows that services are not being charged appropriately or not, and that cuts into the hospital's funding by Medicare. So again, this will change a lot because insurance is playing such a vital role in patient delivery, that if the insurance company is not seeing the results that they'd like to by something as simple as this report, which can be manipulated and changed, then they will ultimately cut those services, and that could harm the healthcare facility in general. So like I said, this data can be skewed in a way that does not accurately report the costing of what is truly occurring and can cause errors across the other sectors of a hospital or healthcare facility's accounting books. And the most important thing to know from all of this is that healthcare is always changing. It's difficult to find one particular way of auditing an accounting system of a hospital or healthcare facility that works. Accounting in the healthcare field in general is just important because it provides an account for effectiveness and efficiency of how any particular healthcare facility is run. Looking at how one cost method compares to another and looking how we currently audit and account for services provided is important to keep the rising cost of healthcare from affecting our general economy. Healthcare changes every day. I mean, it's inevitable, and it is in our best interest to keep our accounting and methodology up to date to meet not only the needs of patients, but for the economic standpoint of healthcare as an industry as well. Again, I'd like to thank you for your time, and my name is Talia Gonzalez.